Excellent. Well, thank you everyone for coming out on this very, very windy day. Glad to have you here. The speaker today is Dr. Lauren Bunch, who's assistant professor of medical humanities and bioethics in the College of Medicine. And she's going to talk to us today about death.
Thank you very much. I really appreciate the invite from Dr. Dow to be here. I'm at UAMS now. I am trained as a philosopher. Just as a little bit of background about me. I'm sort of one of the weird philosophers who ended up working in a hospital. Not the only one, but there's not a ton of us. And I went to a small-ish liberal arts school for undergrad, a little bit bigger than Hendrix, but similar in terms of the kind of philosophy behind the teaching model. So I'm a firm believer in liberal arts colleges, so I was thrilled to be able to come talk to you all today. And my plan is to talk for about 30 minutes or so. I'll have a couple of stops along the way where, kind of initial thoughts or feedback from you all I'll take, and then plan to devote the second half of the hour to discussion. I would say on the front end, I'm probably going to raise a lot more questions than I answer, but I take it I'm among a like-minded crew. Are most of y'all from religious studies or philosophy? Either as a major or minor. Okay, some yes, some no. Anyway, I welcome any of that. This talk is somewhat philosophical, but the philosophy through the lens of somebody who works at a hospital. Anyway, that's sort of my intro about me, and my talk today is more Certa, Hora, Incerta. I have not spoken Latin in a long time, but that is a Latin phrase we'll talk more about philosophical puzzles and defining death. So my goal here is to get you all, hopefully by the end, a little skeptical about definitions of death, as well as thinking about some of the implications for the way that we define death. We often think of death as being this very definitive, black and white, scientifically precise thing. I'm up here to hopefully upend some of that and get you all thinking about some of the consequences that follow when you start to question the definition of death. So this is a Latin phrase or motto. I did not make it up. But it is sort of well suited for this talk. One person has already asked, what on earth does that mean? Does anybody know what this means or have a guess as to the translation? Yeah.
Death is certain of the hours uncertain.
Yeah, nailed it. I think that's kind of the experience I got. Yeah, very well done. So death is certain, the hour is uncertain. The idea being, as you can probably guess, that we all know we're going to die, but we don't know when, we don't know how. I agree with all of that. However, what I'm going to be pushing back on today with what I talk about is this idea of death being certain. Death is certain in the sense that as mortal beings, we will inevitably all die. However, whether someone is dead in some cases is not a certain thing. So I'm going to kind of be pushing back on that. And so just as a matter of truth in the way things are, certainly in the United States and most countries elsewhere, there are legally and clinically speaking 2 ways to die. So what are those? First of those is something as death by circulatory criteria. I'll be working. So what is this? So according to the Uniform Determination of Death Act, which was passed all the way back in 1981, death by circulatory criteria is the irreversible cessation of circulatory and respiratory function. So heart stops beating, you stop breathing, your blood stops circulating in your body. I got an asterisk by irreversible there. That's not there in the original code, but I have it there because we're going to come back to that idea of irreversibility. We're going to think about, in what ways is that word maybe not sufficient for the conversation. And this is, I think, what most people think of when they think about death is heart stops beating, you stop breathing. So that's one way, again, legally and clinically speaking, that you can die in the United States. There's a second way, and that is death by neurologic criteria, or DNC, sometimes also referred to as brain death. Who has heard of brain death? Just out of curiosity. Okay. A lot of people haven't, but y'all are ahead of the game. So what is brain death? According to that same 1981 law, the UDDA, it's the irreversible cessation of all functions of the entire brain, including the brain stem. And again, I've got irreversible start because I think we might want to think about that. And I should also say, so this is a national law that was passed back in 1981, but it is also codified in the state of Arkansas using identical language. So the state of Arkansas says there are two possible ways to die. If you meet criteria for one of them, then you are legally dead. You don't have to meet criteria for both. Meeting criteria for one suffices. And so we talk about death or the cessation of function of the entire brain, including the brain stem. Just as a little bit more of background, the brain stem is the part of the brain at the base of your skull that regulates involuntary stuff, vital bodily functions, the things you do involuntarily, so like your breathing, your heart rate, swallowing, your pupillary reflexes when you've got light or not shining in your eye, your gag reflex, cough, those kinds of things are regulated in the brain stem. So brain death is if there is no brain function happening at all, including at the brainstem. And again, we'll kind of hear more in a minute that might make you push back on this. So this is a more controversial definition of death, is all I want to talk about. You all, it sounded like a lot of you have heard of this definition, but again, a lot of people are not aware that this is someone who meets these criteria is legally and clinically dead. In the work I do in the hospital, this is often a surprise to people who maybe have a loved one who is, has been found to be brain dead or suspected of being brain dead, and the team is informing the family of that. It's not a concept they're familiar with, and so they can understandably have a lot of questions about it. A lot of people have asked and continue to ask. They grant that as a descriptive matter, brain death is legally and clinically death in the United States, but they ask, is it real death? And we can define real in different ways. You might say, is it actually biological death? Is it actually metaphysical death? Is brain death really death, or is it something else? And so why might people question whether brain death is actually quote unquote real death? So the patient or the corpse, depending on kind of what your frame of reference is, can still be breathing when someone is brain dead. Because if someone is brain dead, typically what's happening is they're in an intensive care situation. They have a ventilator. They either have a tube down there in their mouth and their throat called an enterotracheal tube, or they have what's known as a tracheostomy, which is where access is moved down here to the neck. It's just kind of a safer, more long-term way for someone to receive ventilator support. And so if someone has that ventilator support, that ventilator is helping them breathe and doing the breathing for them, right? And so they're still getting oxygen. Your heart can beat, provided it has oxygenation. So your heart can be beating independent of the brain activity. So someone can be breathing, their chest can be moving, their organs, the skin are all perfused, and yet the medical team might be saying, your loved one is dead because they meet criteria for brain death. So that's one reason someone might doubt it. In addition to the fact that you can have a breathing, perfused person in front of you who is brain dead, there are some other bodily functions that can and do continue when someone is brain dead. Facial blushing, so they can get redness in their face, some deep tendon reflexes. There can be some neurohormonal regulation as well as changes. People who've gone through puberty who have been declared brain dead, I'll talk about an example of that in a little bit. Hemodynamic response, meaning that their body is still able to regulate blood pressure, temperature, that kind of thing, electrolyte balance. So some of these critical biological functions and sort of orientation toward bodily homeostasis can still happen. Doesn't mean it always happens. I mean, a lot of times there's deterioration of all of this in someone who's been declared brain dead, but these things can still happen, and commonsensically seem to potentially at least be at odds with a constituent death, right? And then finally, can we really confirm irreversibility? So part of that definition for both ways that someone can die is that this state is irreversible. Can we really confirm that in the case of brain death? And is it really irreversible cessation that's occurring as opposed to current cessation that over time might change? You might especially imagine that maybe with kind of advances in science and technology, there are more therapies available to rehabilitate people who who currently meet the criteria for brain death. And so that would raise some interesting questions about, well, was it really death, but now it's not anymore because the technology has advanced. So can we actually confirm that irreversibility? And I will say that same concern could also apply on the death by circulatory criteria side, although my quibble with irreversibility there is a little bit different, and I'll talk about that. But you might make a similar complaint about that insistence on irreversibility in death by circulatory criteria as well. So here's some reason why it might be a little bit doubtful. And indeed, prominent folks in the field, these are all physicians and bioethicists here, have emphatically said no. The brain death is not real death. They grant that it is legal death because it is the law of the land. They even say that there are maybe some virtues to having brain death be a legal definition of death, but they reject the idea that it is a biological form of death. So Truog and Franklin Miller have labeled it a legal fiction. So again, they grant that legally speaking it is death, but they say that it's a fiction if you're trying to map that legal idea of death onto the biological reality. It says, it's similar to saying things like corporations or persons. That like legally we've agreed to this. Other people, legislatures have agreed to this, and we sort of accept the consequences of that view, but we don't view it as being literally true. So he says that they say the same for brain death. And then John Lantos, who's a pediatrician, bioethicist, he says it's not biological death. He calls it death by convention. And again, says things like biologically dead people don't maintain homeostasis. They don't make urine. That's something else folks who are brain dead still can do. They don't have beating hearts. They don't gestate fetuses. There have been some brain dead patients who have gestated fetuses. They don't secrete insulin. So essentially says it makes no sense to say that a body that is capable of doing all of those sorts of things is dead. He says that corpses are health hazards and people who are brain dead are not. And so it just seems nonsensical. So we've got some very prominent people in the field, 2014, 2012, not that long ago, and their voices are still very much in the conversation. So my first question for you all, and you can think on it some more, I've got more stuff coming that might help you think about this question more, but I'll go on and pose to you, why might we find brain death acceptable or maybe even useful or good, all things considered, to have in society, even if we grant that Robert Truog and Franklin Miller are right and it's legal fiction? Do you see anything beneficial about having this type of definition?
Yeah. I think when discussing like death and stuff, it's being looked at from the perspective of like, or when declaring somebody's dead, it's being looked at the perspective of, and this is going to sound really pessimistic, but they're like just an object to observe. And I think when declaring that somebody's dead, it's like the person isn't just their body, it's also like their conscious and their thoughts and feelings and stuff. And so when somebody would go brain dead, you might have the functions of what's considered normal, but it's that person's not there anymore. You can't function without your brain. Just like a train, like it'll move, but if there's no conductor, it's going to eventually crash into something. So I think the acceptable part is the fact that by kind of like denying the fact that they're no longer there just because of a body's response, involuntary response, seems more like selfish than if you were to just take the idea that they can't do anything, like with the premise of having a thought.
Yeah, got it. Yeah. So your name?
Kaylee.
Okay. Yeah. Anything else? Okay, let's get a couple more to you and then do a few more. Hold on.
I guess people might find it acceptable from a feasibility standpoint. Usually when someone's brain dead, again, like to even still have these functions, they have to be in a hospital under intensive care. People don't have that in their homes. You can like wake up and find your partner brain dead. They just have died because they couldn't breathe in the night. So that could like knowing that they are only doing these responses or breathing due to artificial intervention is maybe what allows you to be like, okay, they are gone from me at this point. I can't get them back.
Yeah, okay, over here and over here. Yeah, these are great.
I was just thinking from a super like useful standpoint, and not saying I agree with this, but it could be good in some way to pronounce somebody dead if their brain's dead, if you wanted to use their heart or something to like transfer an organ. And yeah, I wouldn't know that, but that would definitely be helpful if you need like a live person for their body parts.
Okay, yeah, stay tuned. We'll come back to that in a couple of slides, but yeah, right. And again, yeah, and y'all, again, I kind of want to use this as an invitation of, yes, you do not have to endorse what you're going to say, but just kind of thinking about ways in which this might be, some people might think this could be useful. Yeah.
I was gonna say, I think it provides a good foundation for understanding death. I think just like a lot of times, I guess in philosophy, when people think they have understanding, they kind of go based off of what works now, and then they revise as like more things are discovered. And I feel like right now our understanding of like, I guess the human body and humans in general, the brain does like the majority of the control and regulation, and when that doesn't work, then you're not necessarily alive. And I feel like also like even having like trouble with the definition, I feel like that wouldn't change the fact that death still exists. And I feel like it's good to at least have a foundation that you kind of build up on and like explore your understanding of death, even if like you kind of recognize that maybe this isn't like 100% accurate, but maybe like 95, 99%. It's like kind of getting you there.
Yeah. Okay. Awesome. Well, y'all are making my job easy because you're saying so much good stuff. I'm gonna try to synthesize all of it. These were all great points that I think each touched on. I think these are related but slightly different kind of aspects of why someone might make a case. So I think kind of both of y'all's responses, hearing some stuff about you might not quite put it this way, but I think this is consistent with what y'all are saying, that when we talk about being a person, we're talking about more than just is their heart beating, are they breathing? And I love your point about, this might be something that we refine further, that concepts can be helpful, even if they're just heuristics, even if they're just kind of getting us, close. Someone might argue and say, well, gosh, for death, we probably want to be pretty darn certain, we want it to be that 99 point whatever percent accuracy. But I think that's a great thing to think about, because it also points to the fact that, again, a lot of people think of death as this very objective standard, but we can kind of question that. So there's this question of, is there something more to being a person than just, having respiration occur, having your heart beat? You might take like a Lockean account where you say that, really personhood rests on something like psychological continuity. And so maybe if you either if you lose that continuity, or in the case of someone who's brain dead, you just can lose that consciousness altogether. Maybe that's a really critical part of being a person. Maybe that's something that we value so highly in being human beings, that if that is something that someone is no longer possesses the capacity, then maybe we don't think they're biologically dead, but maybe we think that their life has come to an end in another relevant way. So this thought, some people might say, and there are other people who push back on that, and for very principled reasons. But that's what some folks say, because they think we are more than the totality of our biological functions, and so something like brain death recognizes that in useful ways. And then I'm coming back to this idea of, well, maybe this would be helpful if we were thinking about organ donation. So we're going to come back to that. So what are some problems and puzzles associated with this? I think I've already started to kind of motivate this, but I'm going to talk about a particular case. This is the case of Jahai Mikmath. This is a picture of Jahai here, taken not too soon before she went to the hospital, and what ended up becoming just kind of a famous case in contemporary bioethics happened. So Jahai was a 13-year-old girl living in Oakland, California. This was back in 2013. She was born in 2000. She had sleep apnea, which is a condition where it is hard for you to breathe when you're sleeping. Apnea means you're not breathing, so you'll stop breathing, and usually people wake up. But it's disrupted your sleep and has some associated poor health outcomes. So it's the kind of thing you want to treat, especially in a kid like Jahai. So she and her mom had seen a doctor about it. They made a plan for her to have surgery. So she was getting her tonsils taken out. Was getting her septum kind of straightened because part of her breathing issues were that one nostril was not really able to get much air into it. And then they also did some kind of reconstructive surgery of her mouth and throat, just to really open her throat up to where she was able to breathe better. She had that surgery on December 9th of 2013. We had a week after the surgery. She was in the recovery area of the hospital. It was kind of expected that it was going to be an outpatient type surgery where she would recover for a little bit and be able to go home. While she was in the recovery area, she'd asked her mom if she could get her a popsicle. Their throat was kind of bothering her. And then soon after that, she had a cardiac arrest. They later determined that she was bleeding internally and had a tremendous amount of blood loss that way. That caused her heart to arrest. So really tragic outcome of, a fairly routine surgeries. Certainly not what Jahai's family would have expected was likely to happen given, for the nature of the procedure she was having done. So she was at Children's Hospital Oakland at that time after this happened, and was declared brain dead by the physicians taking care of her there on December 11th. 2 days afterward, she was declared brain dead. And because she was declared brain dead, the hospital wanted to, she was on a ventilator and receiving other types of medical support, and the hospital wanted to remove that medical support. The reasoning being this patient is no longer alive, and so we should not be continuing to, have her on ventilator support, be doing all of this other, ICU level of medical care. The family did not agree with that. And so they petitioned the court to stop the hospital from unilaterally removing the ventilator support from Jahai. And so the state court declared that Jahai was dead, so sided with the hospital in that way, recognized brain death. And I'm looking at my notes here, so I just want to make sure I get the series of votes correct. But they barred the hospital from acting and withdrawing the ventilator. So they said, Jahai is brain dead, but you cannot remove the ventilator. And that went on for a couple of weeks. Kept going back to court and getting that time period extended where the hospital was not allowed to do anything. The McMath family, so that went on for a while. So she was still declared brain dead, still on a ventilator. And her family then said, we want her to get a tracheostomy. So again, like I talked about before, that's moving the tube that helps you breathe in your mouth to here in your throat. Again, it's just a kind of more long-term way to have someone on a ventilator. You're less likely to have infection when it's like this. It's easier to clean and take care of. So they wanted her to have that done, and they also wanted her to get a feeding tube so that she could receive nutrition through the feeding tube. And again, the hospital did not agree with that plan. And so this went to federal court. At federal level, they sided with the hospital in this case. And so the plan is often the case with hospitals. If the hospital says we're not willing to do this type of intervention, they'll say that, well, that we're going to give the family some time to see if they can find a facility elsewhere that would be willing to accept a transfer. If that facility says, well, we'll do these things, then that first hospital will help facilitate the transfer. So they did that. There was kind of more of an out of court settlement that took place between Jahai's family and the hospital, and her, either Jahai or Jahai's body, depending on how you interpret brain death, but she was transferred to another facility, an undisclosed facility where an undisclosed physician did the tracheostomy surgery, did the feeding tube surgery. And then she subsequently was transferred to St. Peter's Children's Hospital all the way across the country in New Jersey. Now, an interesting the legal facts about New Jersey. So New Jersey, like all 50 states, recognizes brain death as legal death. However, they are the one state that has a mandated religious exemption for brain death, meaning a patient in New Jersey may not be declared brain dead if either the patient's family objects to that, or if it is known that the patient would object to that, they were able to participate. So what you have here is a little bit of a legal puzzle where you have someone who is legally dead in California, but not legally dead in New Jersey. Just kind of weird. I mean, you say legally dead, but recognizes dead. And it's a little bit strange to think of somebody's status as either being alive or dead changing when you cross state lines, right? But that's what happened. So she was in New Jersey. There is some kind of disputed evidence offered by her family to suggest that she was improving and they were seeing clinical signs of improvement. She continued to receive somatic support for another 1,600 days after the initial declaration of brain death, and was pronounced dead by circulatory criteria in June 2018. So about 4.5 years after the first declaration of death. So there's a lot that could be talked about with this case. Again, kind of within bioethics, it's still a case that's talked about a lot. More evidence has come out, and there are some folks who are saying that some of the testing that they do in order to diagnose brain death, some of that testing was poorly done, or that the results were misinterpreted. So there's some debate as to whether or not the physicians actually got an accurate diagnosis of brain death. I think her case raises a lot of questions, and we can talk more about that in the Q&A. But this is, again, kind of one of those cases I think really illustrates some of the again, both biological, but also you would say ethical complications, legal complications as well of defining death. So now we're going to go to organ donation, which was already mentioned earlier. And with organ donation is this concept known as the dead donor rule. And the thought is that organ donation should not violate the dead donor rule. And simply put, the dead donor rule says that donors must be dead or must be declared dead. And we could argue about which of those is better, but must either be dead or declared dead before the removal of life-sustaining organs for transplantation. So this rules out things like living donation if you're donating kidney to somebody, if you're donating a lobe of your liver, if you're donating bone marrow, something like that. But things like hearts, things like full livers, things like both kidneys, any other of those life-sustaining organs that we don't do live donation for. Ethics says you need to adhere to the dead donor rule. And now why do we have the dead donor rule? Again, probably obvious, but just kind of throw in a few reasons. This, helps get at the moral prohibition of just killing people, right? I mean, most people would say like, yeah, that would be bad if, Lauren just leaves this, building after her talk today, and someone decides, yeah, we should procure her organs. I certainly have a problem with that. So he gets at that moral prohibition against killing people or undue killing of people. Again, we can refine it, but it gets at that, I think intuition most people have, and all the moral principles and laws around that. It can help act as a wedge against the slippery slope of, maybe we allow more and more people. For example, people in a persistent vegetative state, maybe they're never going to regain consciousness. You could see some enterprising transplant surgeon, hospital team, policymaker saying, there's an organ shortage, and if we were able to extend organ procurement to folks who are in persistent vegetative states, that would free up more available organs. But there's all sorts of worries as to why you would not want to do that. And so this helps kind of prevent that slippery slope from taking place. Hopefully it's grounding some trust in the organ donation system. Again, similarly, people are probably not going to be that trusting of organ donation or organ procurement agencies if, it's not true that donors need to be dead before organs are procured. So it helps guard against that. could probably point to some other reasons, but those are kind of the big three that I see. So all this is to say, I think the dead donor rule is a good thing. And most people do, although some people quibble about how we should understand it, and some people say that it's maybe too strict. So again, there are two different ways to die, and so there's sort of two different pathways of organ donation as a result of that. Organ donation after neurologic death and organ donation after circulatory death. So what are some problems? We can look to DNC and say that if brain death, which is donation or death by neurologic criteria, DND is donation after neurologic death. So if brain death is not real death, then the dead donor rule, depending on your version of it, if you say that they have to either be dead or declared dead, but if you say they have to be dead and brain death is not real death, then it would be impermissible to do organ donation following declaration of brain death. If you're not really dead, can't do organ donation. Some folks can argue brain death is not real death. So, and again, or at the very minimum, we would have to grant that being declared dead is distinct from being truly dead. And again, I think that can run into problems too, because you don't just want people declaring other folks dead without them, being really dead in some sense. And so for one, this would limit the number of organs that would be available for donation. If we were to say, for example, organ donation from folks who've been declared brain dead is not acceptable. Something else kind of important here is that organs from brain death donors are much more viable than organs that come from donors who are dead by circulatory criteria. Because critical to an organ's viability is that ischemia, meaning lack of blood flow and therefore lack of oxygenation to that organ, is minimized. The longer organs are not perfused blood and are receiving oxygen, the less likely they are to be successfully transplanted into a recipient. And so with brain dead donors, they are continuing to be on a ventilator, and so their heart is beating, their organs are being perfused, and so it's pretty minimal the amount of we call it warm ischemic time, which is in contrast to organ donation following circulatory death, because there has to be asystole or no heartbeat for a certain amount of time before organs can be procured, and during that time, the organs have already started to deteriorate. We can talk about that more in the discussion. There's debate over how long body needs to have no heartbeat before that's deemed acceptable, but that's an important just sort of clinical distinction. And then when we talk about organ donation and death by circulatory criteria, so I'm doing a time, okay, I will wrap it up. This idea of irreversibility, just that I would come back to. So cessation of circulation is actually not irreversible in many cases, given the technology that we have. We can do CPR, we can do defibrillation, we can administer pressors to help raise someone's blood pressure while we're doing those other things, and technology is likely to improve even further. And so it's really not, the moment someone's heart stops beating and circulation ceases, it's not irreversible in all cases, because we could do one of these interventions and get their heart started again, right? And so some people have said, well, maybe we can fix that if we say that you're dead if there's a permanent cessation of circulation. The thought being that we grant that there are interventions that we could utilize to reverse this condition, but we have decided not to. And for that reason, it's permanent. So you can make that claim, but then you've really got death dependent on something like intentionality, which seems a little weird, right? Seems like a physical state like death should be independent of, whether I, as the ICU attending physician, have decided we're going to code this patient or not. And something else that we talk about with DCD, and again, I'm going to wrap up, but happy to talk about this more in the Q&A, is how do we ensure that decisions about organ donation are not influencing or improperly influencing decisions about medical care for the patient who is not yet dead, because they have not died yet by circulatory criteria. Typically, when there's a donation after circulatory death, what happens is the patient is on a ventilator, and that ventilator is really the thing that's doing all the breathing for them, keeping them alive, but they don't meet the criteria for brain death. And so what happens is that ventilator support is removed, and eventually the patient's heart stops, and so then they're dead by circulatory criteria. And the worry, and we have some policies in place over at the Children's Hospital to help prevent this, is we don't want decision makers making decisions about whether or not to withdraw the ventilator support purely because they're feeling pressured into organ donation or leave organ donation. We want them making that decision based on the interest of the patient. If that patient is an adult, what that person's preferences and values were, whether this is a, what they would deem to be an acceptable quality of life, those kinds of things. So we want that decision made separately and before any discussion or decisions getting made about organ donation. And so it gets into all kinds of stuff about, coercion, informed consent, people feeling pressured to go a certain way, all of that. So that's really all I have as way of, kind of an introduction and background into this. I've got some questions for discussion up here that are just things that came to my mind as points that might make for some interesting conversation, but I am not by any means needing to limit the conversation to any of this. I'm really, most interested in discussing whatever it is that you all would like to talk about. But thank you for your attention. Any questions, comments, quibbles?
Only from like tangentially related, but is there any like protocol for organ donation with physician assisted suicide or anything like that? Because I know it's not legal here.
Right. Yeah, that is a good question, and I confess to not being super up to speed on. I mean, I like kind of know the states that physician assisted suicide or physician assisted death is legal, but I don't know the intricacies of organ donation there. I suspect, however, that organ donation is probably, well, I was gonna say that I don't think it would necessarily be ruled out from the get-go. Like, I don't think they would say if you're pursuing this, you're not allowed to donate organs. Because I think your question highlights that you might be worried about that. And you might be thinking, is somebody being unduly influenced by the thought of I could donate my organs if I did this? So I don't necessarily think that I don't think it would be ruled out, from the get-go because of that. However, I would suspect that depending on kind of what the method is, and typically it's medication that eventually a person's heart stops beating, that they might not be deemed viable candidates just purely biological perspective, not a like clinical perspective. But it's a good question, and again, I take it that you're getting at that again, that kind of that same worry about what's the basis for this decision, and is it possible that a person is making a decision for reasons that really aren't entirely their own true desire or preference. Yeah.
I'm sort of thinking about like the coercion and informed consent with organ donors, because I'm sort of thinking like, is it even a reality that we can like, I'm thinking like I had a friend who was in a car accident. He was perfectly fine. He was brain dead, and his family was very torn up because the hospital was like, we have this these perfect organs, and they were like really pushing for an organ donation, but like the family is already so like distraught that like this thing has happened, to this person that they care about, and like they're still reeling from everything that's happening. And so I don't know, like can you in a state of mind like that, can you make a decision that's like I don't know,
Truly informed.
Yeah.
I struggle with this question a lot because ethics team gets involved in some of these discussions, and Yeah, I asked that question a lot. I think in so many ways, in a situation like that, you were asking families to just make just an impossible decision. A time sensitive decision, no less. And so I think you were right to wonder about that. There are some families who, you know, had conversations with the patient and know this is what the patient would want. And so while it's still a very devastating circumstance, they feel very steadfast. And, you know, we had these conversations, I had the evidence. And even then, those cases are really hard and conversations are really hard. So when those conversations haven't happened, which is often the case, especially among, you know, younger folks, I think you're right to ask those questions. And there certainly has been tension in the hospital before of, you know, medical team maybe being concerned that the organ procurement agency, because it's there's a procurement agency that talks to families is distinct from the hospital. However, the family might not realize they're distinct because they're showing up wearing scrubs and they have ID badges and all that. And there certainly can be that worry that there might be some undue pressure from them, or just kind of as you are getting at, the situation itself really prevents people from being able to make thoughtful, calm, informed, you know, confident decisions. Yeah. So I don't think I have a satisfying answer other than saying I think that's the right question to be asking, unfortunately.
I'm not trying to make this judgment about like any type of physician, but I do feel like it's fair to ask. When after declaring that they're brain dead and they're deciding about this organ donation, can there be a type of like implicit bias about that, like the value of that person, of them being like maybe we should wait longer, or maybe if they feel like they might relate to that person more based on like backgrounds and things, and then like there might be a sense of more value. Do you think there's any chance of that, or are
Absolutely.
changed?
Absolutely. Yeah. Again, y'all are asking great questions. You know, and the thing about implicit bias is like you don't really have it, right? And I mean, and there's also the chance of explicit bias as well. But I absolutely think that there's all kinds of sort of subtle stuff, it's either conscious or not, that can impact behavior, not just around something like this, but also around kind of more mundane types of things. You know, if a patient might come across to a physician as difficult, but maybe a patient exhibiting that same behavior is kind of given a little more grace because that patient looks a lot like their mom or something like that, you know. So I absolutely think that we should be worried about exactly that kind of thing with all of us. And again, don't necessarily have good solutions for it, unfortunately, other than, you know, you want there to be oversight kind of various layers, and you know, it's not just one person who's, you know, making the decision that, oh, this person's going to be an organ donor from the hospital side. You know, that's something for the family to be deciding. But absolutely, physicians have a lot of authority in terms of saying, you know, we're not going to continue to offer this type of intervention, like in the case of Jahai, where they said, you know, we're not going to continue to offer this, and the family had to take it to court. Which again, kind of getting back to the situation there, and you can like imagine this devastating thing happening to your 13-year-old that you weren't expecting at all, and then on top of that, you're having to advocate for her in these really extreme ways. Yeah. What?
Oh, I did. My it was a question. Oh, sorry.
You sure?
What are the distinct differences between declaring somebody in a comatose and then declaring somebody brain dead?
Yeah, those two are all confused. So with someone who's in a coma has both brain some functioning, but also some higher level brain functioning as well. I'm not a neurologist, so I can't get much into specifics beyond that, and a lot of it's kind of varying patient to patient. But for one, there's an apnea test that's done with brain death, where Medication's version of that is you optimize the patient in terms of their hemodynamics. So like you make sure they're getting good oxygen, you make sure that the carbon dioxide levels in their blood are below a certain level, you make sure their blood pressure is adequate, and then you remove the ventilator and you see if they're able to breathe spontaneously. some in a coma, a lot of folks in a coma are not even on a ventilator, but some who are still able to breathe, some just not enough to, sustain themselves getting oxygen without that ventilator support. Yeah, so short answer is brain activity, very different.
So this question kind of arose after I was trying to like think about, should we allow patients and families to opt out of declaration of neurological criteria? And I guess I was then wondering, so we had the example of someone pronounced dead by neurological criteria. And then later, which I feel like somewhat maybe expectedly, then a person like died of
Circulatory.
Yes.
Yeah.
And I'm assuming the answer would be no to this, but have there been cases where like someone's pronounced dead by neurological criteria and then maybe they do something, obviously not consciously, but that maybe there'd be a conflict because a family member would interpret that as like behavior. I'm thinking about if they were to like twitch or something, whether it's from like just a shock or anything like that. Like if that kind of like blurs.
Yeah. The answer to all of that is yes.
Yeah, like I guess what I'm saying is when I started thinking about should we allow them to I was initially like, well, like you could say like maybe because they're probably never gonna come back. And if they did, definitely like not the same person if they were brain dead. But then it's like, I don't know, have there been cases where people were like, well, maybe.
Yeah. So in Jahai's case, kind of what I'm saying there, after she was moved to New Jersey, that there was the family said that they were seeing signs of improvement and that, folks were debating whether that was the case. One of those was that they would touch her feet or poke her feet and see movement that they said, we didn't used to see those. And so, you've got them saying, well, this looks like an improvement, and then you've got some folks saying, well, no, that's just one of the reflexes that we would still expect to see. But there is but again, there are physicians who have written in the last few years saying that the electroencephalogram EEGs that they did, again, as part of the brain death diagnosis process, they said, well, these were false positives for brain death, and here's the reasons why. And again, I'm not going to get into all that in part because I would not be able to explain it particularly well as a non-physician. But again, there's always that worry of diagnostically are we missing something. Or again, are we going to get technology that we're able to, people's brains are going to be able to be healed or regenerated in ways that they can't currently be. So absolutely, there are questions like that. I guess sort of maybe an interesting point related to that is for adult patients, one brain death exam legally suffices for someone to be brain dead. So if the team does a brain death exam and follows all those steps, and it is confirmatory for brain death, then that patient can be declared brain dead. In pediatric patients, standards require that, and law requires that there be 2 independent brain death exams performed at least 12 hours apart from each other. And my sense, although I haven't seen anyone really articulate it necessarily, my sense is that is in part, one, it's just extra protective because these are children. We tend to be more protective of children than we are adults, and also kind of allowing for the possibility that we know that kids' brains are a lot more plastic and adaptable than adults' brains, and so it's the thought being maybe that it's allowing for that. Some folks have said it's really not clinically supported to do those, to require those 2 exams, and indeed it might just confuse people. I think you can reasonably debate that, but again, just kind of an interesting artifact of all of us. Yeah.
So I'm not like a health person, so I don't know the answer to this. But from my understanding, I thought like reflexes, like twitching and stuff, came from like a stimulation in the nerves, but stimulation in the nerves comes from the brain. So if they're brain dead, how do they continue to twitch and like?
Yeah. And I'm not going to fully be able to give you a satisfying answer to that because I struggle with what Jahai went through puberty. Well, after she did a 3rd brain death, and so I struggle with how can that happen in terms of hormonal regulation and all of that. But my understanding is that, and again, just well, you have to talk to someone who's, really a health person and not a philosopher who works in a medical center to get the nitty gritty on this. But my understanding is that there can be that nerve activity, even in the absence of the signal from the brainstorm. And the same way there can be like cardiac electricity and activity even without the signal from the brain. And again, I know it's not a specific answer, and I struggle with just conceptually how both of these things can be true as well. But yeah, again, I think it kind of points to this question, and this is really that.
So considering if an individual was considered brain dead in the hospital, but there was a finite amount of like ventilators and stuff to go around, and the individual who's brain dead was using it for a long amount of time, does the healthcare facility have any right to like take away and give it to someone who is still like considered living, or should they keep it on? Where how do they share those resources?
Good question. Yeah, because you're pointing to for better or worse, what is often one of the main drivers of healthcare is resource access and also cost, which is tied to that. We can imagine that if that maybe CEOs of hospitals would be less concerned about this question if ventilators were everywhere and it was really inexpensive for people to be sustained on and that kind of thing. But in a case like what you're describing, for one thing, if this like was an expected shortage because it's being like COVID, like we've got a crisis that is driving this, then there are guidelines and crisis standards of care that would kick in that hospitals develop for COVID. And so part of those crisis standards of care involve algorithms for really triaging patients. That's an interesting talk in and of itself, because you can ask, well, what kinds of things should be prioritized? Like, should it be younger people should have more access? Should it be people with children? Should it be people who are doing what we deem to be good things in society? That kind of thing. But in cases like that, someone who's brain dead would score on those things in virtue of that. And then if so kind of yes to your question and the crisis standard of care situation. But even if it weren't the case and it was just it's flu season, and for that reason we've got like a lot of folks who develop pneumonia who are on ventilators. Hospitals, I'm most familiar with UAMS just because that's where I'm at, and Arkansas Children's, but they have what's known as futile or inappropriate treatment policies, where it's a pathway, and it is multi-step and lengthy for good reason, because you want to give the family a chance to respond and argue their side. But it's a kind of a policy pathway for situations in which the hospital is saying this is appropriate for us to continue. And if you go through all the steps of that process, and the ad hoc committees and all of the players who are involved say yes, this is inappropriate, then at that point the hospital will be authorized to unilaterally remove the ventilator. Now we try to avoid that because imagine what that does to a patient's family. And it's atypical for kind of the entire process to play out. Usually either the family says we don't want this anymore, or there's a clinical change in the patient dies, that kind of thing. But yeah, the short of that is there are ways to do that, but it's a lengthy process. And I think lengthy for a good reason. But yeah, good question.
When someone is declared brain dead, is the time of death the time that they were declared brain death, or the time that they remove the ventilator and stuff? So in the case of declaration of brain death, the ventilator doesn't actually have to be removed. So it would be at the time the death is declared. So do they have a death certificate when they are declared brain dead? Mm-hmm. So if they move to New Jersey, they already have death certificate.
Yeah. So Jai's body was released to the coroner, and then the coroner released it to her family, which is releases her family still on a ventilator. Very strange circumstance of events. But yes, you're right, that there was a death certificate for Jai that predated a second death certificate by 4.5 years. Yeah. Yes.
Okay. My question is, what part, like, because I know, like, what parts of the brain have to stop working for somebody to get brain dead? Like, like, is it there from below and the person is no longer conscious, or is it something more than that?
Yeah, so really, you know, like, I don't mean this to sound like glib, but I feel like it might, like, it's really all of it.
Okay.
The definition focuses on the brainstem, like, you're right, I didn't talk about, like, prefrontal cortex, pons, like, I didn't go through kind of everything, again, because I'm not a neurologist or neuroscientist, but the reason why the brainstem is so kind of heavily focused on that definition is because there are a lot of patients who kind of their higher brain, so things like their you know, prefrontal cortex, like you're talking about, those things, there's, you know, profound tissue death and no longer any function there, but the brainstem is still functioning. And so that might be someone who's in a persistent vegetative state, minimally conscious state, that kind of thing. And so that's why the focus really is on the brainstem, because that tends to be the difference maker. But yeah, the full definition is that it's death of the permanent cessation of function of all parts of the brain. Yeah.
Do you know what someone's in a persistent vegetative state? Is it one brain dead? Is it illegal to end services?
So is it illegal to end services in that case? It would be ethically problematic for the hospital to unilaterally end services, barring some sort of inappropriate or futile, but I'm gonna kind of put that to the side because it's usually inappropriate treatment that we're talked about. So at a minimum, there would need to be some policy like that followed. And then where the real robust debate on that type of question is around, is it medically inappropriate to continue interventions for someone who is in a persistent vegetative state? Are y'all familiar with Terry Scheiben's case? Okay, you're also young. When I was like a kid, she was in the news a lot. It was a woman who was in a persistent vegetative state, and there was a big prolonged media coverage of the disagreement between her husband and her parents about whether or not she would want to continue to receive nutrition and hydration, you know, via feeding tubes. So if a family made that decision, or if a patient had made it known, you know, I would not want to continue to receive medical interventions in a case like this, then it could be ethically defensible, but that would need to be something where the conversations were happening and not that it was a unilateral decision. And that alone doesn't solve all the ethical issues that I take it are, you know, the basis for your question. And there's a lot of debate. You know, there certainly is worry about, we're discounting someone who has a disability if we say that somebody who's in a persistent vegetative state shouldn't receive interventions. And again, you can think about all sorts of slippery slopes that you could worry about there.
I think we have time for one more question. Anyone?
Yeah, thank you all for the great questions. Yeah.
So if we were in a Jane or John Doe type situation and this individual had no family to reach out for, do they just rely based on the hospital's first response, like, well, we can no longer help this person, so we can't help this person, so they cease services, or like, is that like typically how it goes because there's no one else to reach out to?
Are you imagining that like a patient is brain dead?
Like you just found someone knowing it's
come in and they had a traumatic brain injury. Yeah, so yeah, and these are a lot of what I see is heartbreaking. This is one especially heartbreaking situation where you have what's known as an unrepresented patient. So the hospital is unable to find any contact. So hospital and social work really are the superheroes here. Ethics helps some, but it's primarily social work. Really, in cases like that, does their darndest to find contacts, even if it's someone like a neighbor. We've had some patients who we find out are homeless, and maybe we find out that they spent some time in a shelter, and so we'll seek out either other folks who are staying at that shelter or like any of the leadership or admin. So we really try to find somebody, even if it's not like a blood relative. But even in those cases, you're right, sometimes that doesn't happen. So again, just talking kind of policy stuff without getting too into the details, but we do have a policy for what to do in cases like that. And it's never particularly satisfying because you really, would like to find someone who actually knew the patient, even if just a little bit. But we have, policy in place that says that for end of life decisions for an unrepresented patient, 2 attending physicians have to come to the conclusion that, let's say, withdrawal of the ventilator in this case is the most medically appropriate thing to do, and ethics sort of weigh in to come to that conclusion. There have been questions, I don't know if this was part of what you were asking, but questions about should those folks be candidates for organ donation. I have concerns about that because, again, I think that can really just look like we are taking advantage of an extremely vulnerable person. But I know at least one time when the organ procurement folks tried to make the argument in favor of it, but that was squashed by my colleagues and other folks. But you can make the argument of, again, we don't have nearly enough organs for folks on the list. So yeah, but that's what would happen. But again, really tough situation that never feels satisfying at the conclusion.
And what we have you here, before we thank our speaker, Dr. Wilson, there's also on the topic of medical humanities, a handout for you.
So we've heard a lot of references, and you have a living example here of a philosopher working in the medical field. You may have seen that we have a new grant from the Mellon Foundation to do projects in health humanities. It's going to be over the next 3 years, but what I'm going to say is there's $75,000 in funds for Odyssey projects, for projects that take place this summer and next fall. And the deadline is April 1st. So any project that relates in some way human health and or healthcare to arts and humanities is possible to fund. So I have a bunch of handouts here. If you're interested, pick one up, ask me questions.
Please take advantage of that. I'm like, I wish I were ready for that.
If you join me, thank you. I want you to talk more with us today.